Good evening again, my dear friends and viewers, our CEC members and fans from all over the world and from Egypt as well. We are back to you with this second part of the Sports Cardiology Guidelines. The European Society of Cardiology Guidelines 2020 was updated this year, and for the first time they publish specific guidelines for sports and cardiology. 2 weeks ago, we started with the introductory part, or the first part, which was actually involving the introduction and how to manage the situation in generally, how to classify the sports, how to classify the cardiac conditions related to the sports, and how to give ourselves some algorithms about managing these conditions. The second part of the guidelines is the big part, actually, is the part full of data, and it includes a vast majority of all the cardiac situations that will face a clinical cardiologist. We are glad and honored to have tonight with us Professor Yasser Alauddin Abdulatif, the lecturer of cardiology and consultant of cardiology at Ain Shams University and a very eminent member of the cardiovascular rehabilitation group there. Dr. Yasser will go with us smoothly, and he will take his time. And also, I know this is going to be a very big session. So also, our dear viewers, take your time and leave your questions on the chat on the YouTube. Every 15 to 20 minutes, we can take a very small break for questions and discussions. And we will go smoothly through this part of the guidelines until it's finished, inshallah. I will not make the introduction any bit longer. So, Dr. Yasser, you are most welcome, and you can start sharing your slides, please.
Thanks, Professor Zahran, for the introduction. We are glad to continue today the European guidelines on sports and exercise in patients with cardiovascular disease. This is part 2. Last time we discussed a general introduction about cardiovascular disease risk and benefit in patients, in healthy individuals, in patients at cardiovascular risk and aging population. We took the general outlines for this last time, but the continuation of the guidelines specifically addresses different clinical scenarios and different clinical settings. We have to stress that these guidelines is just guidance, not very comprehensive. We have to follow a guidance for us. We have to know some key messages from each clinical entity, how to discuss with the patient. It is a patient-physician shared decision-making, not a strict recommendation. Just we will discuss with the patient the risk to exercise, the risk he can do this. We can see many of the recommendations is class to be within these guidelines. We'll start with different clinical settings. Our topic today will be divided into several sessions. We will address chronic coronary syndromes. We will have also, including coronary spontaneous coronary artery dissections and myocardial breach, anomalous coronary artery disease, and then we'll shift to chronic heart failure patients, then cardiomyopathies, whether dilated, hypertrophic, arrhythmogenic, LV non-compaction. Then we will switch to the setting of arrhythmias and devices. Then lastly, we'll tackle shortly a general guidance on congenital heart disease. First of all, we'll discuss the chronic coronary syndrome. If we have a patient is a 30.
Yes, sir, would you please share your slides? Share your screen.
Okay. We'll start with chronic coronary syndrome. We have a case of a patient. He's a 36-year-old gentleman who is dyslipidemic, body mass index 29 kilogram per meter square. He gave a history of previous myocardial infarction, non-STEMI, 8 months ago, and underwent PCI with 1 stent. His echo revealed an LV ejection fraction is 55%. He's currently symptom-free. He was previously practicing tennis, and the patient wants to re-practice tennis. What are your recommendations? What can be our recommendations? First of all, tennis, according to the previous lecture, can be categorized as a high, single tennis is a high intensity sport. So the importance of this classification when we resort to the type of sports we are attempting to exercise. We have football adapted would be a low intensity, while a professional basketball, competitive basketball or competitive football or handball will be a high intensity sports. Swimming as recreational will be a low intensity, whereas mid and long distance swimming will be a high intensity. So this is very important to memorize, not to memorize or to resort to it when we are trying to risk stratify our patients. We'll discuss first of all, beyond this case, the recommendation for exercise in individuals at risk of atherosclerotic coronary artery disease and asymptomatic individuals in whom coronary artery disease is detected at screening. As we previously discussed, if we have a patient beyond 35-year-old, we have to risk stratify the patient for coronary artery disease, as it is a cause of the most causes of sudden cardiac death is related to atherosclerotic coronary artery disease. So among individuals with asymptomatic coronary syndrome, defined as coronary artery disease without inducible myocardial ischemia on a functional imaging or conventional exercise stress test, participation in all types of exercise, including competitive sports, should be considered based on individual assessment. If I have asymptomatic chronic coronary syndrome and I did a functional imaging modality that revealed no inducible myocardial ischemia, I can participate in any type of competitive sport, and it is recommended. But what about the factors that determines the risk of adverse events during intensive exercise or competitive sports in asymptomatic individuals with long-standing coronary artery disease? These factors should include the type and level of sport competition, as we have mentioned, the fitness of the individual patient, the profile of cardiovascular risk factors, the presence of exercise-induced myocardial ischemia or exercise-induced arrhythmias, and or evidence of myocardial dysfunction. These are the factors that I will going to build my decision making. So what about the high risk features for exercise-induced adverse cardiac events in patients with established atherosclerotic coronary artery disease? It will be with the presence of critical coronary stenosis, whether more than 70% in a major coronary artery or more than 50% in left main disease, with on coronary angiography, or FFR less than 0.8 or IFR less than 0.9. If we have a critical coronary stenosis, baseline LV ejection fraction less than 50% and wall motion abnormalities, this portends a high risk for exercise-induced adverse events. We should know this. Inducible myocardial ischemia on maximal exercise test, non-sustained VTAC, polymorphic or very frequent PVCs at rest and during maximal stress, or recent acute coronary syndrome plus or minus PCI, or surgical revascularization within less than 12 months. This will have, with portends a high risk features for exercise-induced cardiac events. As in this algorithm illustrated in these guidelines, if we are going to clinically evaluate and recommend sport participation in individuals with established coronary artery disease, will do a functional stress test. If we don't have inducible myocardial ischemia and the patient is asymptomatic LV ejection fraction more than 50%, no exercise-induced arrhythmias, the patient will be at low risk. And what's recommended? Exercise echo, not rather than the vitamin echo, which is not available in Egypt. Exercise echocardiography is the best modality, recommended modality for athletes we can assess for assessment. So if we have no inducible myocardial ischemia, asymptomatic, LV ejection fraction more than 50%, and no exercise-induced arrhythmias, the patient will be at low risk. However, if we had inducible myocardial ischemia, we'll do an invasive coronary angiogram. What is the risk after that for the coronary lesion? If low risk lesion, and the patient asymptomatic, ejection fraction more than 50%, no exercise-induced arrhythmias, this will be a low risk for exercise-induced complications or sudden cardiac death, and may participate in intensive exercise programs, although some restriction may apply, especially for those elderly patients. But if we had a risk of coronary lesion that is high-risk lesion, whether more than 50% left main, more than 50% proximal LAD, 2 to 3 vessel disease, more than 50% or 90 or more than 90% lesion in a vessel, I have to do revascularization. If it is possible, and the patient will become low risk after that, and he can exercise. However, if it is not possible or ongoing symptoms of ischemia, despite medical therapy, may participate in skill competitive sports at mild to moderate intensity leisure sport like golf playing. He can do this. This is the algorithm suggested by these guidelines for patients with established coronary artery disease. Our patient here, after can do a stress test. If he is asymptomatic, as he claims, LV ejection fraction more than 50%, and no exercise-induced arrhythmias, he can re-practice tennis. But we have also to stress that individuals with inducible ischemia during functional testing, despite adequate treatment, should undergo coronary angiogram. Those with high-risk lesion should have revascularization prior to considering high-intensity exercise programs or competitive sports. And individuals with high-risk coronary feature may gradually return to sports 3 to 6 months after successful revascularization, pending a normal maximum exercise or functional imaging test. So if the patient had a high-risk coronary features and successfully revascularized, he may gradually return to sport 3 to 6 months after undergoing normal maximum exercise or functional imaging test. And these are
yes, yes, sir. Can we take a break with a couple of questions, please?
Okay.
So thank you for this nice presentation. I'd like to ask about a kind of patient with inducible exercise ischemia on high workload. How would you prescribe exercise for this patient, and what would your advice for this patient?
On high workload, developing
yes.
Inducible ischemia?
Yes, let's say inducible ischemia on running more than 6 minutes. I know the guidelines mentioned that if we have inducible ischemia, the patient should go to coronary vascularization. However, in the patient with chronic coronary syndrome, this patient can benefit from medical treatment with inducible ischemia on a high workload. So what's your advice regarding exercise in this patient?
We mentioned in a couple of minutes this in the guidelines. If we cannot, it's recommended if I will do a competitive sports, I should revascularize the patient.
Okay.
But
so, okay, please go on. Yes.
Okay. And if I am going, if revascularization is not amenable for revascularization or for any reasons, we can do exercise and stop at a maximal exercise test. if inducible ischemia at, for example, as you have said, at 6 minutes or about 70% of VO2 max, I can exercise him to a sub anginal level, for example, at 50% of the VO2 max, and this will come in a couple of minutes within these slides. This is the slide. Leisure time exercise below the angina and ischemic thresholds may be considered in individuals at high risk of exercise-induced adverse events, including those with persistent ischemia. So I have to tailor the exercise. It will be leisure time exercise. It will be below the anginal and ischemic threshold. We can do this for these patients. But according, this is completely different from if we ask, is the patient will need to do revascularization or not? If the patient CCS angina level at class 1 or class 2, Canadian classification 1 or 2, will start, of course, with medical treatment.
Yes, that's great. But however, this is a class 2B, so there is no strong evidence regarding this recommendation. I think it should be tailored patient by patient regarding the prescription of exercise in these patients with inducible ischemia on the high workload. Do you agree, yes, sir?
Yes, I agree. I agree, because this patient, according, we have to stress that these guidelines are just guidance, not strict guidelines.
Okay.
During the guidelines, we will mention every time you have to share your decision with the patient, not a strict recommendation. And this can apply according to the recommended algorithm. If we cannot revascularize the patient, is not possible, or ongoing symptoms or ischemia despite medical therapy, he may participate in skill competitive sports and mild to moderate intensity leisure sports. This can fit, according to your question, I think can fit here, where we can do skill competitive sports, mild to moderate intensity, leisure sports, and we cannot recommend and we cannot guarantee that the patient play football competitively. This would be will have some risk for the patients.
Great, Yasser. And revascularization leads us to another question regarding the antithrombotic treatment in the patient that would like to exercise. What will be your advice to this patient?
He will try as much as he can to avoid contact or bodily contact exercises, like boxing, like falling, risk of falls, because he can develop hematomas, bleeding risk, intracranial hemorrhage, especially patients with concomitant oral anticoagulation, which will be at very high risk of bleeding. So try as much as he can. So if he is on dual antiplatelet therapy, and especially if he will take concomitant even with single antiplatelet therapy and anticoagulation, to avoid any bodily contact exercises. And
thank you, Yasser. And thank you, Yasser. You can continue with your presentation, please.
Okay. So the risk stratification, as we will continue our recommendation. So we have to risk stratify for exercise-induced adverse events is recommended in individuals with established long-standing chronic coronary syndrome, and we have to regularly follow up our patients, and individuals at high risk for adverse events are managed according to current guidelines on chronic coronary syndromes. Competitive or leisure sports activities, with some exceptions such as older athletes and sports with extreme cardiovascular demands, should be considered in individuals at low risk of exercise-induced adverse events. So the main message, so the patient should be at a low risk for exercise-induced adverse events, and competitive sports are not recommended in individuals at high risk for exercise-induced adverse events or those with residual ischemia, with the exception for individually recommended skill sports, as Dr. Karim asked about this point, and this is very crucial and very well asked questions. Another issue, what are the recommendations for return to exercise after acute coronary syndrome? Here comes the importance of exercise-based cardiac rehabilitation. which is recommended for all individuals with coronary artery disease to reduce the cardiac mortality and rehospitalization. During the initial period, motivational and psychological support and individualized recommendation on how to progress the amount and intensity of sports in patients with coronary artery disease, and all sport activities should be considered at an individually adapted intensity. And we have stressed that every week that exercise is delayed requires an additional month of exercise to accomplish the same level of benefit. So we have to start the exercise cardiac rehabilitation as soon as possible after sustaining an acute coronary syndrome, and will last for 8 to 12 weeks. We'll start by also low to moderate intensity recreational sporting activities parallel with the structured progressive exercise programs at the cardiac rehabilitation unit. He is practicing regular exercise, and then gradually increase his exercise activity. And we have to stress that in individuals with non-ST elevation myocardial infarction or chronic coronary syndrome who have complete revascularization and don't have residual ischemia, exercise training can be progressed at a faster pace and until the recommended exercise level is reached, unlike patients with ST segment elevation myocardial infarction. So our patient who had non-STEMI, successful revascularization, symptom-free, will undergo functional exercise testing. If no inducible ischemia, we recommend he gradually can return to practice tennis, but of course, after he should have had a cardiac rehabilitation program first before attempting to re-practice tennis at full power. Another issue, the second issue we'll discuss today, anomalous origin of the coronary artery. We have to know the normal features of coronary artery anatomy in humans, a number of osteoid 2 to 4 arising from the right and left anterior sinuses, the orientation about 45 to 90% of the aortic wall, not acute take-off, as we will mention later on. And the proximal common stem will be for the left main, that gives LAD and circumflex. The proximal course from the ostium to the destination. It courses in the mid-course subepicardially. It will be with branches adequate for the dependent myocardium, and the essential traitors are already covered with the right coronary, LAD, and OM, and terminating in the capillary bed. This is the normal anatomy. What about the most frequent anomalous origin of coronary arteries that's associated with risk of sudden cardiac death, which is important during exercise? If the left main arises from the right coronary cusp, here the left main can course in front of the pulmonary trunk. This is benign condition, not a malignant course. But if it courses between the aorta and pulmonary septum, it's a malignant course associated with sudden cardiac death, or it courses interseptal course and become compressed during exercise, which is another course that is associated with sudden cardiac death, or it can course posterior to the aorta, which is a benign course. So the most important here that the anomalous origin of the left coronary artery, whether interarterial course or coursing as through an interseptal course. This is, will cause repeated bursts of ischemia and consequent increase in myocardial fibrosis and the susceptibility to ventricular arrhythmias during exercise. Also, the acute take-off from the aorta results in a slit-like orifice with reduced lumen. So we have two conditions of anomalous origin of coronary artery disease associated with sudden cardiac death. The acute take-off from the aorta, causing a slit-like orifice with reduced lumen, and the course between the aorta and the pulmonary artery is associated with the greatest risk for sudden cardiac arrest during exercise. So the recommendation for these patients when considering sport activities, evaluation with imaging tests to identify high-risk patterns and exercise stress tests to check for ischemia should be considered in individuals with anomalous origin of the coronary arteries. So inducible ischemia and CT coronaries is very important to assess the anomalous origin of the coronary arteries. If the patient is asymptomatic with an anomalous coronary artery that does not course between large vessels, does not have a slit-like orifice with reduced lumen and or intramural course, competition may be considered after adequate counseling on the risk, provided there is absence of inducible ischemia. So if we excluded these conditions and also done an exercise stress test that did not show an inducible ischemia, we can consider involving in competition or competitive sport can be done, can be considered. And this also, like Dr. Karim has mentioned, these recommendations all are weak. But after surgical repair of an anomalous origin of a coronary artery, participation in all sports may be considered at the earliest of 3 months if they are asymptomatic and no inducible myocardial ischemia or complex cardiac arrhythmia during maximal exercise test. So after surgical repair, at the end of surgical 3 months, we have to ensure that the patient does not have inducible myocardial ischemia or complex cardiac arrhythmias during maximal exercise test. And participation, as we have mentioned, is not recommended if for these patients at high risk of sudden cardiac death. What about myocardial bridge? The same applies. Different variants are there. This is the normal LAD. You can have either a shallow bridge or a deep bridge. If we don't have an inducible myocardial ischemia or ventricular arrhythmias during maximal exercise test, patient can participate in either competitive or leisure time sports, can be and asymptomatic individuals, class 2A. However, competitive sports, if we have, are not recommended if we have myocardial bridge plus persistent ischemia or complex cardiac arrhythmias during exercise stress test. Lastly, in this patient of coronary syndrome, we have patient with spontaneous coronary artery dissection. If we have a patient with a spontaneous coronary artery dissection and underwent percutaneous
Sorry,
intervention.
Yasser, for interruption. Before going with the SCAD, so let's just highlight that the anomalous origin of the coronary artery is the second leading cause of sudden cardiac death in athletes after HUCM. So HUCM is the leading cause, and the anomalous origin of the coronary arteries is the second common cause. And the two malignant courses are the interarterial course and the interseptal or intramyocardial course inside the interventricular septum. And those two situations are situations where the coronary can be actually squeezed during the exercise in both situations, leading to sudden cessation of the coronary blood flow affecting this territory. My question is, because actually this is a jumping question, is there any screening method for athletes that would allow us to find such an anomaly other than performing a multi-slice CT on a routine basis?
Just CT coronary angiography can reveal this, and of course, IVUS can be of a help during the coronary intervention. Just don't have.
Yes, but you cannot do a screening test. You cannot do a screening test for this.
If we had exercise
You
in
just
myocardial ischemia.
I think that
yes, if you
based
get
on
an
symptoms,
exercise in this myocardial.
Zahran, I think screening Dr. Yasser is based on symptoms. So we till now we can't go for CT angiography for screening of an athlete without the presence of any symptoms they have.
Yes.
What's your opinion, Yasser?
I think so. But for competitive sports, for elite athletes, I think it is suggested that we should do CT coronary angiogram to outline this anomaly, because also exercise test rarely reveals myocardial ischemia. Rarely
I
reveals
know
myocardial.
that this is included in the routine pre-requirements before you get a contract with some elite player for some elite club. They perform the multi-slice coronary CT angio, and they even perform a cardiac MRI as one of the routine pre-signing tests for this particular player. but it is not actually mentioned in the guidelines, but it is there in some specific highly selected situations. Thank you so much.
If
Yes.
I may interrupt,
Yes, Haitham, please.
if I may interrupt, Zahran, the problem, Kareem, and all of us, we cannot depend on symptoms in professional players because of the long training they have from the childhood, make the reserve more evolved than the normal individuals. So they can bear the ischemia or the symptoms more than the regular person, and they have an exercise tolerance more advanced than the regular persons. So that's why they do not have symptoms till late, or their first presentation is sudden cardiac death. This is a dilemma because these athletes do not have symptoms. They even translate any symptoms due to the vigorous exercise, not to a cardiovascular related abnormalities. And this is a dilemma that we are all facing. How to screen these patients. I don't think that anyone has a clear answer, including the European guidelines. What do you think, Yes?
I think so. They avoided going into mentioning the recommendation for screening the patients. We did not address at all this issue because it is an arguable issue. No strict recommendation are there. Every society or every country has its own recommendation for participation for screening the athletes. But I think this is maybe included in screening for professional athletes. I think so. Because it is a major cause of sudden cardiac death, the second cause after
sudden cardiac death.
After hypertrophic cardiomyopathy. That
Yes.
may not be revealed
Yes.
during exercise test because it is intermittent.
Yes. Yes, you are totally right. Totally agree with you. Thank you so much. Yes, I think you may proceed now.
Okay. Proceeding rapidly to a spontaneous coronary artery dissection. If we did a percutaneous, successful percutaneous intervention, we'll treat and follow the same recommendation as long-standing chronic coronary syndrome. If we did not do an intervention and allow for spontaneous healing, according to if there is a high-risk anatomy, whether in the left main proximal LAD or multivessel disease, without inducible myocardial ischemia, after that, we can proceed to leisure activities or competitive sports based on individual assessment. However, if there is a high-risk anatomy, will proceed according to the long-standing chronic coronary syndrome. The same applies. To sum up, if we do a successful intervention or spontaneous healing, we have to ensure by exercise-induced myocardial ischemia is there or not, and abnormal multi-slice CT, as mentioned in this recommendation, in patients with documented SCAD who are symptom-free without inducible myocardial ischemia on maximal stress, or with complete healing on multi-slice CT scan, resumption of leisure time activities or competitive sport should be considered based on the individual assessment. So we have discussed addressed the topic of chronic coronary syndrome, whether patient is asymptomatic or patient with after acute coronary syndrome, or patients with anomalous coronary arteries, myocardial breach, or SCAT. There comes the second topic today. Will address patients with chronic heart failure. So exercise intervention should only be initiated in clinically stable individual after medical therapy for heart failure has been optimized. And we have key components before commencing an exercise program and sport participation for patients with heart failure. These are the general recommendations. I have to exclude contraindication to exercise, to perform a baseline assessment, and optimize medical therapy, which is important. Optimization of medical therapy according to guidelines, including device implantation when required. Second, exclusion of contraindication to exercise in patients with hypotension or hypertension at rest or during exercise, unstable cardiac condition, disease, deteriorating symptoms of heart failure or myocardial ischemia despite therapy, or severe and suboptimally treated pulmonary disease. These are the exclusion, general exclusion for of contraindication to exercise. Then we can perform a baseline assessment through a cardiological evaluation, including the severity of heart failure by echo, by BMP, by doing a maximum exercise, preferably cardiopulmonary exercise test to assess functional capacity, the presence of exercise-induced arrhythmias or hemodynamic abnormalities for exercise prescription. And we have to say also that aquatic exercise hasn't been recommended for individuals with heart failure due to concerns about consequence of hydrostatic pressure may not be tolerated, although a recent meta-analysis have shown can be safe and clinically effective. As regards patients asking for aquatic sports, whether swimming or practicing handball in the pool, this will be cannot be tolerated sometimes by the patients. So the general recommendation for participation in sports in heart failure, we have to preliminary optimize heart failure risk factors and therapy. This is class 1 recommendation. Number 2, patients with heart failure who are at low risk based on complete assessment and exclusion of all contraindication in stable condition for at least 4 weeks and near function class 1 status, we can participate class 2A. However, for stable, asymptomatic, and optimally treated individuals with heart failure with mid-range ejection fraction, non-competitive, low to moderate intensity recreational sports can be considered. However, high intensity recreational sports adapted to the capabilities of individuals may be also considered in heart failure with mid-range ejection fraction. But in heart failure with reduced ejection fraction, high intensity sports are contraindicated, class 3 recommendation. And this is the optimal exercise training dose for patients with chronic heart failure. We can exercise 3 to 5 days per week, optimally daily, 40 to 80% of VO2 peak according to the preliminary exercise test for 20 to 60 minutes, continuous or interval, and progressively increasing training regimen at least 3 to 6 months to adjust the duration and the level of exercise, combined with 2 to 3 days per week balanced training exercise, 10 to 15 repetition in at least one set of 8 to 10 different upper and lower body exercises. The same recommendation, but in heart failure with preserved ejection fraction, we have to stress that moderate endurance and dynamic resistant exercise together with lifestyle intervention and optimal treatment of cardiovascular risk factors are recommended. This is not about, we do recommend exercising in patients with HFpEF. This is very important. This is class 1 recommendation, and competitive sports may be considered in selected stable patients without abnormalities on maximal exercise testing. So the general recommendations for heart failure, as we have mentioned, that we have to exclude contraindication to exercise, perform baseline assessment, and optimize medical therapy. After that, we can go for exercise if patient at low risk, stable condition for at least 4 weeks, and near functional class 1, we can recommend the exercise. And in patients with HFpEF, we do recommend moderate endurance and dynamic resistant exercise together with lifestyle intervention, and optimal treatment of cardiovascular risk factors are recommended. The third topic today will address the valvular heart disease. General rules that patients with asymptomatic individuals with mild to moderate valvular dysfunction who have preserved ventricular function and good functional capacity without exercise-induced myocardial ischemia, abnormal hemodynamic response, or arrhythmias are considered at low risk and may participate in all sports. And patients with mild mitral pulmonary regurgitation or tricuspid regurgitation are common among trained athletes and are likely to present a feature of athletic heart and no risk at all to exercise professionally. However, individuals with exertional symptoms, symptomatic, moderate or severe valvular dysfunction, left or RV dysfunction, pulmonary hypertension, and exercise-induced cardiac arrhythmias or abnormal hemodynamic response are considered at high risk. These are the general recommendations. We will discuss every valvular dysfunction in full details later on. What about aortic stenosis? We divided the guidelines in order not to make any problems. Actually, recreational and leisure sports are comparable to competitive sports because the guidelines mentioning first recreational and leisure sports, then competitive sports according to every valvular lesion. So according to these guidelines, the aortic stenosis participation on all recreational sports involving low intensity, if desired, may be considered in individuals with LV ejection fraction more than 50% and normal blood pressure response during exercise. However, participation in competitive or recreational exercise sports moderate or high intensity are not recommended. So low intensity, class 2B, high and moderate or high intensity in severe aortic stenosis is not recommended at all. These are for competitive sports. Mild is recommended, moderate, class 2B to low to moderate exercise in individuals with LV ejection fraction more than 50%, good functional capacity, and normal blood pressure response during exercise. So we have to do an echo, function more than 50%, good functional capacity, and normal blood pressure response during exercise. However, in severe aortic stenosis, patients with asymptomatic severe aortic stenosis, sometimes we can consider low intensity exercise, skilled sports like golf, provided that the LV ejection fraction beyond 50%. This is very important. However, contraindicated to do any exercise with a moderate or high intensity in severe aortic stenosis. What about aortic regurgitation? The guidelines here, mild is recommended class 1, moderate asymptomatic aortic regurgitation can be considered with non-dilated LV and LV ejection fraction more than 50% at normal exercise stress test. However, severe aortic regurgitation involving low to moderate intensity, if desired, may be considered if we have mild or moderate dilated LV, but LV ejection fraction more than 50% at normal exercise test. However, moderate or high intensity sports is not recommended if I have a low ejection fraction below 50% or exercise-induced arrhythmias. What about bicuspid aortic valve? In absence of aortopathy, if I don't have aortopathy, exercise recommendations for bicuspid aortic valve are identical to those in individuals with tricuspid aortic valve dysfunction. So if I have aortopathy, I will manage according to the guidance for aortopathy. If I don't have aortopathy in our bicuspid aortic valve, the same recommendation for tricuspid aortic valve stenosis will apply there. What about mitral regurgitation? If we have mild, as we have mentioned, mild asymptomatic is recommended to do exercise. Moderate for regurgitation, class 2A, as for as aortic regurgitation, and can do all recreational sports, provided I have normal dimension, LV end diastolic diameter less than 60 millimeter, LV ejection fraction more than 60%. The systolic pulmonary artery pressure is important, less than 50 millimeter mercury at normal exercise test. However, severe mitral regurgitation and can do low to moderate intensity, provided I have the same parameters as LV, the dimensions are below end diastolic diameter less than 60, ejection fraction more than 60%, resting pulmonary artery pressure less than 50, and normal exercise test. However, participation in competitive sports is not recommended if LV ejection fraction is below 60%. What about mitral valve prolapse associated with mitral regurgitation? It increases the risk of sudden cardiac death. What is the cause? The potential cause? That the mechanical strain of the mitral valve prolapse on the papillary muscle and adjacent myocardium is thought to be responsible for causing myocardial scarring, which is the mechanism of life-threatening arrhythmias in some individuals. And individuals with mitral valve prolapse should be evaluated with exercise test, 24-hour Ecg monitoring. So individuals with inferior T-wave inversion or PVCs arising from the LV should undergo a CMR to check specifically for the myocardial fibrosis affecting the infrabasal wall. This is an important issue. If we have an athlete, a professional athlete, and I have to assess him before doing a competitive sports, a competitive football playing or whatever, and I have detected that the patient did an echo and has mitral valve prolapse. What is my recommendation? I have to screen for the high risk features for causing increased risk of sudden cardiac death with mitral valve prolapse. If I did an ECG and I find a T-wave inversion in the inferior leads, or long QT, or bileaflet mitral valve prolapse, or family history of sudden cardiac death, or documented arrhythmias, or I did a CMR that revealed a basal infralateral wall fibrosis, or severe mitral regurgitation, or severe LV dysfunction. These are the risk markers for sudden cardiac death. But however, due to the benign nature of mitral valve prolapse, if I have the patient is asymptomatic patients with mild or moderate mitral regurgitation, in absence of the aforementioned risk factors, he can participate in all competitive sports and leisure sports. So the patient, if he is asymptomatic mitral valve prolapse with mild or moderate mitral regurgitation, and absence of all the above aforementioned risk factors, he can do any sports. But what about severe mitral regurgitation? The patient, if asymptomatic with severe mitral regurgitation and no above high risk markers, he can compete to do low to moderate intensity sports after detailed discussion with their specialist in presence of all the other parameters of the end-diastolic diameter, LV ejection fraction above 60, resting pulmonary artery pressure less than 50, and normal exercise test. We can discuss with the specialist and with the athlete himself. But if we have symptomatic patient with mitral valve prolapse and any of the above aforementioned high risk factors, he should not participate in recreational or competitive sports at all and should be discouraged.
So please, yes, sir, before we skip the mitral or we're going to the mitral stenosis, because this is an everyday patient, the mitral valve prolapse. So what's your recommendation if we discovered that any patient which are more than common in our practice have mitral valve prolapse? Do you recommend doing an exercise ECG for him, especially that these patients are young, in the childhood or the early adulthood? Most of them are trained and they do practice sport. So do you recommend that these patients or these other young adults perform an exercise ECG as a routine once the mitral valve prolapse is discovered?
Yes, the guidelines mention this in that full text, that individuals with mitral valve prolapse should be evaluated with exercise test and 24-hour ECG routinely. So
okay, because this is a major turn in our practice. We tend to believe that mitral valve prolapse is a very benign condition, especially if there is no mitral regurg, and we tend to advise our patient to continue in his sports without any precautions. So this is a major turn, I think, in the practice, that every patient with mitral valve prolapse should do an exercise ECG and 24-hour ECG monitoring.
Yes, yes, this is mentioned in the guidelines because it increases the risk of sudden cardiac death, and this is mentioned recommended by the guidelines. There are no recommendations specifically written by level of evidence, but this is mentioned in these guidelines. This is new also for me, that you have to do exercise test and 24-hour ECG monitoring to reveal either the presence of a tube inversion in the inferior leads or ventricular or PVCs arising from the LV. And if we have PVCs from the LV, he should undergo CMR to scan for myocardial fibrosis.
Okay,
Thank you so much, Lee.
Thank you, Aysam and Yasser, for these nice comments. I'd like to add a comment that the crucial step is the diagnosis of mitral valve prolapse, because we encounter an overdiagnosis of mitral valve prolapse. So the mitral valve prolapse is defined by more than 2 millimeter displacement of one or both leaflet of the mitral valve beyond the annulus. This is the definition of mitral valve prolapse. Not every bellowing is a mitral valve prolapse. We should have this definition as a crucial steps and to go on in the screening of the patient with mitral valve prolapse. Do you agree, Yasser?
Of course, because overdiagnosis will, according to these guidelines, a patient will participate in competitive sports will be a problem, a major problem for him. So we have to stick to the guidelines of echocardiography, as you have just highlighted, that we have to properly diagnose the presence of mitral valve prolapse in long parasternal view by the displacement of one or both leaflets more than 2 millimeters into the atrium below the annular level. This is very important. Thanks, Dr. Karim, for mentioning this.
So I'd like to ask another question regarding is the screening with exercise test and 24-hour Holter is recommended for every patient with a mitral valve prolapse or for just a patient that wants to exercise?
I think it is recommended here. It's mentioned if you is contemplating to do exercise. It is not as we have always know. I think we did not encounter that we have routinely to do exercise tests for all our mitral valve prolapse patients.
Yes, I agree. Yes. Thank you so much, and you can proceed, please.
Okay. Lastly, we'll mention the mitral stenosis. The mitral stenosis is categorized according to European guidelines, different from the American guidelines, into mild, if the area above 1.5, moderate from 1 to 1.5, or severe if the mitral valve area is below 1 centimeter square. If we have mild mitral stenosis, it is recommended to do exercise, provided that the resting pulmonary artery, systolic pulmonary artery pressure is less than 40 at normal exercise test. Moderate mitral stenosis, class 2B, to do low or moderate intensity exercise with resting systolic pulmonary artery pressure less than 40 millimeter mercury and a normal exercise test. But however, in severe mitral stenosis, whether doing moderate or high intensity exercise is not recommended at all. Our participation in any competitive sport is not recommended, of course, in severe mitral stenosis like aortic stenosis. And this is for the mitral stenosis. So to sum up about valvular heart disease, mild valvular dysfunction, asymptomatic mild valvular dysfunction, okay for exercise, regardless any type. Moderate whether regurgitation or stenosis, moderate he can do accordingly, whether class 2A or class 2B. However, in severe aortic stenosis contraindicated, severe mitral stenosis is contraindicated, severe aortic regurgitation or mitral regurgitation, according to some echocardiographic parameters, we can undergo low to or moderate intensity exercise. This is for the summing up of valvular heart disease. Then we come to a small another issue of aortopathy. We have to mention, we will give some key messages that a dilated aortic root beyond 40 millimeters is not a feature of an athletic heart at all. It is not benign if we have a dilated aortic root beyond 40 millimeter as a feature of athletic heart. Number two, because of the increased blood pressure and wall stress associated with intensive exercise, these are associated with an enhanced risk of expansion of the aorta and acute aortic dissection. So they have a risk for exercise in patients with aortopathy. And these are the classification. We cannot memorize everything in this classification. However, low risk patients are those with aortic diameter less than 40 in bicuspid aortic valve or tricuspid valve, or Turner syndrome without aortic dilatation. This can do any sports they can ever undergo. However, patients at high risk, these are the patients who are with severe aortic dilatation, more than 45 millimeter in Marfan syndrome or other hereditary thoracic aortic disease, more than 50 millimeter in bicuspid aortic valve or tricuspid valve, Turner syndrome with more than 25 millimeter per meter square, or tetralogy of Fallot more than 50 millimeter, or after surgery sequelae. These are the high risk categories, and we have in the intermediate, low to intermediate risk or intermediate risk, we cannot memorize all of this. However, low risk patient can do any exercise. High risk patients, exercise should be contraindicated. Intermediate risk, only skill sports. Low to intermediate risk, avoid high or very high intensity exercise. Contact, this is important. We avoid contact and power sports, and preference for endurance over power sports. So these are the recommendations prior to engaging in exercise risk stratification with careful assessment, including advanced imaging, CT or CMR at exercise testing with blood pressure assessment is recommended. Regular follow-up, including risk assessment, is recommended. Dynamic exercise should be considered more suitable than static exercise. Participation in competitive sports activity except power sports should be considered in low-risk individuals. Participation in leisure sports may be considered in high-risk individual class 2B. However, patients are at high risk. We don't recommend competitive sports at all. This is for aortopathy. Then we'll address serially after that the issue of cardiomyopathies according to its type, whether hypertrophic and other cardiomyopathies thereafter. The hypertrophic cardiomyopathy is number one risk of at risk of cause of sudden cardiac death in individuals less than 35 years. Yeah, that 35 year athletes. So we have to risk 35 patients with hypertrophic cardiomyopathy by history, by symptoms, history of cardiac arrest or syncope, or individuals with exercise-induced symptoms. Number two, by doing resting and ambulatory ECG for 48 hours to detect the presence of arrhythmias. Number three, by echo to measure the LV wall thickness, left atrial diameter, LVOT gradient, whether resting or provoked by Valsalva, sudden standing, light exercise on spot by squatting. These are the recommendations for the echo. We can resort to exercise stress echo if we have SAM but no or mild to moderate LVOT obstruction. Also, CMR will confirm the diagnosis, and late gadolinium enhancement will reveal the myocardial fibrosis. Also, exercise test is routine to be done to detect abnormal blood pressure response or exercise-induced symptoms or arrhythmias. However, genetic testing should not be performed only for familial cascade screening and not for risk stratification. And also, what's important, mentioned in previous guidelines, the ESC risk score for 5-year risk, whether less than 4%, 4 to 6%, more than 6%, who don't memorize this score. This score depends upon, according to a calculator, you can enter the age, history of syncope, family history of sudden cardiac death from hypertrophic cardiomyopathy, maximal LV wall thickness, left atrial diameter, LVOT obstruction, and non-sustained VTEC. And from these parameters, we can detect the risk score of 5 year less than 4%, 4 to 6% moderate risk or high risk. This is important. Why? Because lately there was becoming a growing recommendation not to avoid totally sports in patients with hypertrophic cardiomyopathy, but to risk stratify them, and uh, we can participate in high intensity exercise or competitive sports if desired, with the exception for those where occurrence of syncope may be associated with harm or death, may be considered who don't have any increased markers of increased risk following expert assessment. If we have a patient with hypertrophic cardiomyopathy wants to participate in sports, although it is class 2B recommendation, but we can give him some guidance. If you don't have cardiac symptoms, if you have moderate, less than moderate risk score, less than 4%, LVOT obstruction, less than 30 millimeter mercury, no abnormal blood pressure response, no exercise-induced arrhythmias, he can, however, with weak recommendation, undergo participate in high intensity or competitive sports. However, in patients with any marker of increased risk following expert assessment, we can participate in low to or moderate intensity recreational exercise if desired. These are just that change. However, participation in high intensity exercise is not recommended for individuals who have any markers of increased risk. This is a class 3 recommendation. So another issue I have to stress that participation in all competitive sports, if desired, may be considered for individuals who are gene positive but phenotypically negative. Once more, patients who underwent familial screening and his brother was diagnosed to have hypertrophic cardiomyopathy, and he did genetic screening and revealed to be gene positive for hypertrophic cardiomyopathy. But he did an echocardiogram that is free from any signs or echocardiographic signs of hypertrophic cardiomyopathy. Can he participate in sports? We'll give him a recommendation. He can participate in sports. However, this will be a class 2B recommendation. What about
So
arrhythmogenic?
yes, sir, before you continue from here, this is the most common cause of sudden cardiac death during sports activity is hypertrophic cardiomyopathy. And you mentioned here what's most important is the five high risk features that would mandate the patient to withdraw himself from actually performing the activity, which is the previous syncope or cardiac arrest, or the high risk score by the ESC score, or the LVOT obstruction more than 30 millimeters of mercury, abnormal blood pressure response to exercise, and of course exercise-induced arrhythmias. What if the patient performed a surgery, the myomectomy surgery for the hypertrophic cardiomyopathy, or if he performed an alcohol septal ablation, and this high risk feature was actually resolved? Let's say that the high risk feature was a high gradient, and this feature was resolved. Do you think it would be wise to advise him to be back to his sports activity, or he still abandoned from performing this activity?
This is a difficult question because there is no recommendation as regards after myomectomy at all. I revised the guidelines, no recommendation. However, I think he can class 2B, but we can do a CMR to detect the presence of extensive fibrosis. If we have extensive myocardial fibrosis, more than 15%, the patient may be still at risk of ventricular arrhythmia or sudden cardiac death.
Yes, because this is a substrate for
Not the problem.
re-entrant ventricular tachycardia.
I think so, because the problem is not about the LVOT obstruction alone.
Yes.
The problem is related also to the presence of myocardial fibrosis. I
It's a,
don't
it's
know.
a, it's a pathological phenotype, as you said. Maybe the only one that can be accepted from this if he has a negative phenotype. He does not have phenotype means features. So he does not have any physical features. This is the phenotype. He's negative. He does not show the physical features of hypertrophic cardiomyopathy, but he's genotypically positive, means that he carries the gene, but the gene is not expressed as a feature. So he's phenotypically negative. This is the only exception where you can still allow him to perform his exercise. Thanks a lot, Yasser. Maybe the arrhythmogenic cardiomyopathy also is a very interesting topic.
Yes, just I mentioned because if we have, like we mentioned before, as regards the hypertrophic cardiomyopathy, if I have a 12-year-old male that is symptom-free, wants to get engaged in an Ahli basketball team, his parents gave a history that his brother sustained a syncopal attack during exercise, echo and CMR confirmed the diagnosis of arrhythmogenic cardiomyopathy, and we hear he stressed during the guidelines that it is not arrhythmogenic RV dysplasia. The new terminology is arrhythmogenic cardiomyopathy because it can involve either the right ventricle or left ventricle, although it affects the right ventricle more commonly. So this is because of the terminology of arrhythmogenic cardiomyopathy. But the player underwent an echocardiogram that was normal. But you have just mentioned, dear Dr. Zahran, that the patient here is susceptible for being for arrhythmogenic cardiomyopathy, but however, he is phenotypically negative. Phenotypically, he is normal. How would you advise this player? What do you think, dear Dr. Zahran?
Before I see this part of the guidelines, actually, my routine maybe, let's say, from what we learn from similar case scenarios, is that the patient already performed an echocardiography that was normal for the
And his
particular
brother
patient, but the brother has a problem with his echo and CMR. So most probably this patient has a genotype that is positive, but probably the phenotype was negative because he did not show any features on the imaging technique used. Maybe I would advise this particular player to perform a CMR as well, because this is the gold standard for diagnosis. And if the CMR showed, like the echo, that it is phenotypically negative, I mean that the LV and the RV both are normal in this particular disease, maybe I would allow a watchful participation in the sports. I mean, she can perform or he can perform the sports activity, but if any arrhythmias happen or any high-risk features appear on the recurrent or repeated imaging for the follow-up every 6 months, maybe I would change my decision.
Okay, let's see what's the recommendation of these guidelines. The guidelines mention that the regular and high-intensity exercise programs are associated with acceleration of the disease process and worse outcomes. So we have an increased risk from the exercise with patients with arrhythmogenic cardiomyopathy. This is the main message we want to deliver to our audience, that patients engaged in competitive sports were at twofold increased risk of ventricular tachyarrhythmias or death and earlier presentation of symptoms compared with patients who participate in recreational sports and sedentary individuals. And among patients engaging in competitive sports, early age of sports initiation was associated with premature presentation of symptoms and adverse clinical profile. Also, reduced exercise intensity was associated with a substantial decrease in the risk of arrhythmias. Also, 20 patients in a registry in patients with implanted ICD or continued to participate in regular competition, 20% of athletes with arrhythmogenic cardiomyopathy received a shock during exertion compared to 10% at rest during a median follow-up of 44 months. That means that exercise is extreme risk factor for progression of the disease in arrhythmogenic cardiomyopathy. This is our message. So how to risk stratify these patients? By history, presence of symptoms, history of cardiac arrest or unheralded syncope, and individual with symptoms attributed to arrhythmogenic cardiomyopathy will undergo low-intensity recreational sports only. Number two, we have to perform resting and ambulatory ECG. the presence of extensive T-wave inversion affecting more than or equal 3 precordial leads or T-wave inversion in 2 out of 3 inferior leads is a risk factor. The presence of non-sustained VTAC or significant burden of ventricular ectopy more than 1,000 only during 24 hours, even in asymptomatic individuals, confers at increased risk for fatal arrhythmias. Also echo to establish the diagnosis. But however, as you have mentioned, dear Dr. Zahran, that CMR confirms the diagnosis and help risk stratify the RV and quantify the myocardial fat infiltration and or scar. The more extensive the disease, the higher the arrhythmic risk. Also, routinely, we can do exercise tests. However, here, unlike hypertrophic cardiomyopathy, genetic testing is of prognostic value because carriers of multiple pathogenic variants in that same desmosomal gene or mutation in more than or equal 2 genes may have an almost 4-fold higher arrhythmic risk than those with a single mutation. So to sum up, unlike hypertrophic cardiomyopathy, the same risk stratification is there doing history, resting and ambulatory ECG, echo, CMR, exercise test. However, genetic testing here is important and recommended, unlike in hypertrophic cardiomyopathy. And patients with arrhythmogenic cardiomyopathy, participation in higher intensity should be discouraged at all, especially in young and male patients, especially young and male patients. And here are the recommendations that participation in 150 minutes of low intensity exercise per week should be considered for all individuals. Class 2A, participation in low to moderate intensity sports, if desired, may be considered for some individuals with no history of cardiac arrhythmias, unexplained syncope, minimal structural abnormalities, less than 500 PVCs in 24 hours, and no evidence of exercise-induced complex intervention. However, high-intensity recreational sports are not recommended in arrhythmogenic cardiomyopathy, including those who are gene positive but phenotypically negative. So, as Dr. Zahan mentioned, the patient should undergo genetic testing, okay? If he is gene positive but phenotypically negative, despite this, participation in high-intensity recreational sport in the basketball team or not, it is not recommended at all for this patient. This is very important for in these guidelines. Also, we have
Yes,
to annually.
I would like to mention here, Yasser, that this is because actually of the difference in the pathophysiology between arrhythmogenic cardiomyopathy and hypertrophic cardiomyopathy. Arrhythmogenic cardiomyopathy, also known as ARVB or arrhythmogenic RV dysplasia, which involves RV and LV fibrofatty infiltrations, and it is a progressive disease because it involves the aberrancy of the desmosomal activity. So it involves repeated fibrofatty infiltration, which is progressive, and it can be triggered. And as you mentioned here, it can be triggered by performing exercise more rapidly than being triggered but with the patient having rest. This is different pathophysiology than the hypertrophic cardiomyopathy. And when we understand the pathophysiology here, we understand also why the difference comes in their computation. Although the screening and the imaging techniques available for both include genetic and include cardiac MRI and include ECG features, because it also involves arrhythmias in both of them and involves phenotypical changes in CMR. But actually, the difference in the pathophysiology, how this disease causes sudden cardiac death versus hypertrophic cardiomyopathy causing sudden cardiac death mainly from obstruction and then from recurrent re-entrant arrhythmias. But in arrhythmogenic artery dysplasia, the fibrofatty infiltration is the main issue, which is actually progressive and can be triggered. Thank you, yes.
This is for arrhythmogenic cardiomyopathy, and this is unlike what expected from LV non-compaction. Because LV non-compaction, we have just a diagnostic challenge because athletes often demonstrate LV hypertrabeculation and up to 8% they fulfill the echocardiographic criteria for the diagnosis of LV non-compaction. and it is hypothesized that an increased cardiac preload may unmask LV trabecular morphology. Because we are doing exercise, we can find that the echo of an athlete may demonstrate LV hypertrabeculation, and I may mistaken it for the presence of LV non-compaction. So we have to take care. But we can exclude this, but by the absence of LV systolic dysfunction, function is not less than 50%, symptoms suggestive of cardiac disease or positive family history of LV non-compaction, besides some other echocardiographic criteria and the CMR findings. However, such athletes will require further CMR, exercise echo, Holter monitoring to assess the presence of LV fibrosis, cardiac thrombi, cardiac contractile reserve, and exercise-induced complex arrhythmias. However, the clinical outcome of LV non-compaction are determined by the presence of symptoms, severity of LV dysfunction, and the nature of ventricular arrhythmias. There are no reported adverse cardiac events in the absence of LV dysfunction, regardless of the severity of LV trabeculation. So, in absence of LV dysfunction, there are no increased risk. And this is apparent in the recommendations that a diagnosis of LV non-compaction in athletic individuals should be considered if we fulfill the imaging criteria in association with the cardiac symptoms, family history of LV non-compaction or cardiomyopathy, LV systolic dysfunction, diastolic dysfunction, thin compacted epicardial layer or abnormal in the CMR or echo, or abnormal 12-lead ECG. Also, participation in high intensity exercise and all competitive sports, if desired, with the exception where syncope may cause serious harm or death, may be considered in asymptomatic patients with LV non-compaction, provided the LV ejection fraction more than 50% and no frequent or complex ventricular arrhythmias are there. So the most important point in LV non-compaction is we are not with diagnostic challenge with the athletic heart, so we have to depend on symptoms and other criteria in other than whether in the echo or CMR or 24-hour or 12-lead ECG. Number two, that the key determinant of the risk is the presence of impaired LV ejection fraction, and the participation in high intensity or competitive sport is not recommended in any of the following, whether symptoms, LV ejection fraction less than 40%, or presence of complex ventricular arrhythmia. And the same applies for gene positive for LV non-compaction, but phenotypically negative patients. What about dilated cardiomyopathy, which is much we can face in our clinical practice? Ventricular arrhythmias are common in dilated cardiomyopathy. We have to mention that, like Dr. Haitham asked last time about hypertension, and with doing an echo, we may be facing diagnostic challenge whether the LVH is related to the presence of hypertension or to athletic heart, whether in the LV non-compaction the same hypertrabeculation is there. Also, the athletic heart may have dilated dimensions, so may present a diagnostic challenging dilemma. So, but LV cavity enlargement in trained athletes that is not associated with systolic dysfunction and outside the context of a familial disease represent a benign physiological adaptation if it is consistent with the type of sports participated, usually endurance sports, and the body size of the athlete. If we have dilated dimensions and the athlete is practicing as a professional endurance sport professional, this can be accounted for the LV cavity dilatation. However, mildly reduced ejection fraction in athlete with enlarged LV cavity should not be merely considered as a normal adaptation. This is important. If I have an athlete and his LV ejection fraction 45%, I won't say that it is normal and I have to further investigate or do other diagnostic tests to reveal, even we can resort to CMR to exclude the presence of dilated cardiomyopathy. But what about the recommendation in patients with truly diagnosed dilated cardiomyopathy? Can he exercise? He can participate in low to moderate intense recreation exercise, regardless of the ejection fraction, in absence of limiting symptoms and exercise-induced ventricular arrhythmias. This is for the recreational exercise, not competitive exercise. What about the competitive exercise class 2B recommendation in absence of the following, or fulfill all the following, that the mild, in absence of severely reduced ejection fraction? Here the key cutoff value for the ejection fraction is 45%. If I have an ejection fraction from 45 to 50% with absence of ventricular arrhythmias on ambulatory Holter monitoring exercise test, absence of late gadolinium enhancement on CMR, no fibrosis, and the ability to increase the ejection fraction by 10 to 15% during exercise, and no evidence of high-risk genotype, which is lamin A, C, or filament C, I can do exercise. However, if the function is less than 40%, 45%, or symptoms of cardiac arrest or unexplained syncope or premature the presence of ventricular arrhythmias or extensive late gadolinium enhancement or high-risk genotype, so this is contraindicated to participate in high or very high intensity exercise test. So to sum up, in dilated cardiomyopathy, I have to do risk stratification. I have to correctly diagnose that he has dilated cardiomyopathy. Number two, ask for symptoms of cardiac arrest or syncopal attack. Do a proper echocardiography to detect, properly assess the LV ejection fraction. To do an ambulatory Holter monitoring to see the presence of frequent or complex ventricular arrhythmias. To do an exercise test. To do a CMR. To do a gene testing to detect if there is a high-risk genotype. So this is a large list to do for a patient with dilated cardiomyopathy before contemplating to participate in competitive sports. Then we will have to myocarditis. This is the non-ischemic inflammatory disease of the myocardium, which may cause cardiac dysfunction and arrhythmias. Here we have a patient, a football player who is 17-year-old football player who developed upper respiratory tract infection followed by symptoms of heart failure. 3 weeks later, echo was done revealing ejection fraction 30%. What are your recommendations regarding return to his sports? Firstly, rapidly will mention that the diagnosis.
This is important because also in the COVID era, Yasser, I think we are seeing some patients with post-COVID viral myocarditis, and sometimes we do them an echo and we find a pericardial effusion or we find a reduced global systolic function, and then we also ask ourselves, what is the next step and when will they be able to return back to their physical exertion, and when they can be returning back also to performing the sport activity. So this also is a question of the hour, as they say. So please explain this. Yes.
Rapidly, we'll mention, this is not our topic today to mention the diagnosis, but rapidly we'll mention that for diagnosis to be established, we have to do serum cardiac troponin will be elevated due to myocardial involvement. ECG has low sensitivity, but some ECG changes we can see ECG changes varying from T-wave change or ST elevation can mimicking myocardial infarction. Also, there are some recognized echocardiographic features of overt myocarditis, including non-dilated LV cavity with increased myocardial wall due to edema. CMR is the most useful for to establish the diagnosis, and especially T1, T2 mapping for extracellular volume fraction, and also for assessment of the late gadolinium enhancement for the non-ischemic pattern. That is very diagnostic by CMR. Also, the endomyocardial biopsy is the gold standard for the diagnosis of a myocarditis. What about the prognosis for the myocarditis? This patient developed myocarditis. What is his fate? about 50% of individuals, they reveal full resolution of LV function within 30 days. 25% will show persistent cardiac dysfunction, and however, 12 to 25% will progress to permanent heart failure. So LV dysfunction is an important prognostic factor in the long term. So half of the patient with myocarditis show full resolution, 25% persistent cardiac dysfunction, and 12 to 25% will develop permanent heart failure. What about our recommendation for exercise for individuals with myocarditis? What's important? Comprehensive evaluation, as we have mentioned. Exercise test, Holter monitor is recommended following recovering from acute myocarditis to assess the risk of exercise-related sudden cardiac death, because this player wants to return to sports. He sustained myocarditis. Then, after complete resolution of a myocarditis, he can return to sport or not. Return to all forms of exercise, including competitive sports, should be considered after 3 to 6 months. In asymptomatic individuals, normal troponin and biomarkers of inflammation, normal LV systolic function on echo and CMR. We will do another CMR. No evidence of ongoing inflammation or myocardial fibrosis on CMR, good functional capacity, and absence of frequent and or complex ventricular arrhythmias on ambulatory Holter monitoring or exercise testing. So in order to advise him when to return, there must be at least 3 to 6 months, patient asymptomatic, troponin negative, echo will be done, CMR is normal, good function capacity, exercise test done, and ambulatory Holter monitoring revealing no frequent or complex ventricular arrhythmias. And participation in moderate to high intensity exercise for a period of 3 to 6 months after acute myocarditis is not recommended at all. So complete rest is the rule there. And participation in leisure or competitive sports involving high intensity in individuals with residual myocardial scar and persistent LV dysfunction is not recommended at all. If he had persistent LV dysfunction, we don't recommend returning back to sports. And also for pericarditis, but the period of holding the exercise will be for 30 days to 3 months for individuals who have recovered completely for acute pericarditis, depending on the clinical severity. If there is not severe, only 1 month. If the pericarditis was severe with pericardial effusion and fever and troponin was positive, and there we will hold the sport participation for about 3 months, and participation is not recommended with also for patients with constrictive pericarditis. So myocarditis will hold sports for at least 3 to 6 months and will not return to sports unless everything is normal. And also for pericarditis, will hold exercise for 30 days to 3 months, then before resumption of sport participation once more.
Yes, sir. Could I ask a question, please?
Of course.
Regarding the myocarditis, it is the recommendation stated that we should have no evidence of ongoing inflammation or myocardial fibrosis on cardiac magnetic resonance. So should we repeat the cardiac magnetic resonance, say to do a CMR at the index disease, then to do a follow-up cardiac MRI to detect any ongoing inflammation or fibrosis?
Yes, this is the recommendation. This recommendation, because the patient came after resolution of the symptoms and echo became normal and wants to resume sport participation, and will ask us, will ask you, can I resume the exercise participation once more? He had to do, according to the guidelines, class 2A recommendation, another CMR, normal LV systolic function on echo and CMR, no evidence of ongoing inflammation or myocardial fibrosis on CMR. This is stated, and this is new for me also. I have to do CMR because before giving the permission for the individuals to resume his activities, competitive sports.
And the second MR should be done after 3 to 6 months.
Yes, because he has should be symptom free and fulfilling all these criteria in order to resume the competitive sports.
Okay. Thank you. Yes.
Thank you. I think we had several new information today from this guideline, which is, I think, new to many of us. We have discussed so far the clinical setting of chronic coronary syndrome, valvular heart disease, heart failure, remaining only the arrhythmias and channelopathies, and rapidly we'll discuss the congenital heart disease. But we'll discuss now the arrhythmias and channelopathies. But we'll have a general management framework for patients with arrhythmias or potentially arrhythmogenic condition. We have to ask ourselves three principal questions, as we have done in heart failure. Is there an increased risk for life-threatening arrhythmias or not? How does one control symptoms due to arrhythmias during sports, but also at rest? What is the impact of sports on the natural progression of the arrhythmogenic condition? As we have seen in the arrhythmogenic cardiomyopathy, the exercise has a negative influence on the disease progression. First of all, we discuss a patient with atrial fibrillation. Patient without atrial fibrillation but at risk develop at risk of developing heart failure. Moderate regular physical activity is a cornerstone in the prevention of atrial fibrillation through modification of its predisposing factors. However, atrial fibrillation is more prevalent on the other side in active and former male master athletes and those performing high-intensity endurance sports, suggesting the presence of a U-shaped relationship between habitual exercise and atrial fibrillation. This association hasn't been confirmed in females. To repeat once more, we recommend patients at risk of developing atrial fibrillation is recommended to do regular physical activity in order to modify the risk factors. However, they did find in master male athletes, they have much more prevalent development of atrial fibrillation. So regular exercise is recommended, class 1 recommendation, or counseling about the effect of long-lasting intense sport participation on atrial fibrillation is recommended in individuals with atrial fibrillation who exercise vigorously. And what's important from this all, after avoidance of evaluation of structural heart disease, thyroid dysfunction, alcohol abuse, or etc., the new recommendation as in atrial fibrillation is that atrial fibrillation is ablation, AF ablation is recommended in exercising individuals with recurrent symptomatic atrial fibrillation and or in those who don't want drug therapy given its impact on athletic performance. That patients who are participating in sports with atrial fibrillation, they should undergo atrial fibrillation, AF ablation, class 1 recommendation. Also, the ventricular rate while exercising with atrial fibrillation should be considered in every exercising individuals by symptoms and or ECG. Also, during ablation, we can recommend cavo-tricuspid isthmus ablation in patients who with documented atrial flutter who want to engage in intensive exercise to prevent flutter with one-to-one AV conduction. Let's explain this, that patients with who develop exercise, even with atrial fibrillation, they can develop atrial flutter, at risk of atrial flutter. And when atrial flutter develops, it may conduct at one-to-one AV conduction. So to prevent this, patient with documented flutter, they should undergo cavo-tricuspid isthmus ablation. And we can do this as a on prophylactic basis in individuals with AF who want to engage in intensive exercise in whom class 1 drug therapy is initiated. Because patients taking, for example, propafenone or flecainide are at risk of developing atrial flutter and which can conduct one-to-one AV nodal conduction. So we'll do prophylactic cavo-tricuspid isthmus ablation. Also, class 1 recommendation as monotherapy without proof of adequate rate control during exercise is not recommended. Yeah, to sum up, we don't recommend, we recommend atrial AF ablation in patients contemplating sports, and we have to avoid sports with direct bodily contact or prone to trauma are not recommended in patients exercising with atrial fibrillation on anticoagulation. Second,
So, so the regular physical activity is given a very strong recommendation, class A level of evidence, class 1 level of evidence A, regarding the prevention of atrial fibrillation. Does this apply for initial attacks or paroxysm or both?
I think it is not clear from the guidelines, but patients who developed atrial fibrillation once and we have risk factors like hypertension, like diabetes, like obesity, at risk of redeveloping of atrial fibrillation, I think we can recommend doing regular physical activity because it reduces the risk of redeveloping atrial fibrillation or prevent the presence of atrial fibrillation. However, a patient with persistent atrial fibrillation, we cannot, it is not recommended. We can exercise, but it is not recommended to do a regular physical activity. Patients with persistent atrial fibrillation, it is not recommended. However, we can exercise, of course, provided rate control or rhythm control, whether by drugs or preferentially via atrial fibrillation, via AF ablation.
Okay, thank you, Yasser. You can proceed.
Secondly, we have paroxysmal supraventricular tachycardia and Wolff-Parkinson-White syndrome. The key message from these guidelines is the presence of pre-excitation. We don't have any problem in patients with supraventricular tachycardia or AV nodal reentrant tachycardia without pre-excitation. And without associated structural heart disease, it is not life-threatening. Although the arrhythmia can cause dizziness, exhaustion, and syncope is uncommon. However, pre-excitation is important to detect pre-excitation because it may be associated with sudden death. Therefore, it is important to exclude the presence of latent pre-excitation by performing carotid sinus massage or adenosine test in sinus risk, because 1/3 of patients with Wolff-Parkinson-White syndrome may develop atrial fibrillation that can conduct over the accessory pathway and leads to ventricular fibrillation. So given the fact that atrial fibrillation is more common in athletes, pre-excitation constitutes a prognostic concern in athletes. An evaluation of the athlete with ventricular pre-excitation should exclude associated structural cardiac disease such as hypertrophic cardiomyopathy or Epstein anomaly. So the guidelines here states that comprehensive assessment to exclude latent pre-excitation, structural heart disease, and ventricular arrhythmias is recommended, class 1 recommendation, and also participation in all sports activities is recommended in patients with paroxysmal supraventricular tachycardia without pre-excitation. It is recommended. However, in patients with accessory pathway, ablation of the accessory pathway is recommended in competitive and recreational athletes with pre-excitation and documented arrhythmias. And patients without pre-excitation, curative treatment by ablation can be considered. So this is easy guidelines as regards supraventricular tachycardia. There is no major risk without pre-excitation, major risk with pre-excitation. Patients with accessory pathway should have ablation, and also patients without with supraventricular tachycardia without pre-excitation, class 2A recommendation can be treated also by ablation. What about the presence of prematures or non-sustained VTAC on the ECG of a patient during screening for exercise prescription? We all know that PVCs with a response to exercise, but the reduction or resolution of PVCs, as we all know, with increasing exercise load is typical of idiopathic and benign ventricular arrhythmias, particularly those with an outflow tract morphology. However, PVCs induced by exercise should be considered as red flag. As we all know, during stress test, if we have benign PVCs during on baseline ECG. If it disappeared, it is of benign etiology. However, induced by exercise, this will be a red flag for us. But the most important task in individuals with PVCs or non-sustained VTAC who want to engage in sport is to exclude underlying structural or familial arrhythmogenic conditions, since sports activity may trigger sustained VTAC. And according to the recommendation of the guidelines, if patient will want to be engaged in sports or participate in sports, if exercising individuals with more than or equal to PVCs on a baseline ECG or one PVC in the case of high endurance athlete, we have to thoroughly evaluate the patient through a detailed family history to exclude underlying structural or arrhythmogenic condition is recommended. Among individuals with frequent PVCs and non-sustained VTAC, a thorough investigation with Holter monitoring, 12-lead ECG, exercise test, and suitable imaging is recommended. Class 1 recommendation. And all competitive and leisure sports are permitted with periodic re-evaluation in individuals without familial or structural underlying disease. This means that we'll screen the patient, will allow him to do exercise if he had no family history or structure underlying disease. This is all for the presence of prematures in the ECG of an exercising athlete. What about long QT syndrome? Long QT syndrome, what's more important, since the risk of cardiac events during sports activity is largely gene specific, especially long QT1. Genetic testing and cascade screening of family members should be performed following a clinical diagnosis of long QT syndrome, because individuals with long QT1 are at highest risk during stressful exercise. And all patients with exercising with long QT syndrome with prior symptoms or prolonged QT should be on therapy with beta blockers at target dose and should avoid QT prolonging drugs and electrolyte imbalance, such as hypokalemia or hypomagnesemia, and shared decision making the same for genotypically positive, phenotypically negative long QT syndrome. However, participation in high intensity recreational sports, even when on beta block, is not recommended if the QT, corrected QT more than 500 or genetically confirmed long QT with QT corrected more than 470 in men or 480 milliseconds in women, and participation in competitive sports with or without ICD is not recommended in individuals with long QT syndrome and prior cardiac arrest or arrhythmic syncope. If you have implanted ICD for long QT syndrome for sudden cardiac death, you will not be allowed also to participate in competitive sports. Lastly, in the arrhythmias will be the Brugada syndrome, that is based on specific echocardiographic ECG changes. And most individuals with Brugada syndrome, we have to say unlike other arrhythmias, they are asymptomatic throughout their lives. If you have Brugada syndrome in the ECG, they are almost asymptomatic throughout their lives. However, in the majority of cases, events occur during sleep or rest, during febrile states, or occasionally from heat stroke, related to fever or sleep or rest, and not related to the exercise. And patients who suffered sudden cardiac arrest or an arrhythmic syncope should undergo, of course, ICD implantation. So there is no much increased risk of exercise on patients with Brugada syndrome. However, we can say the same recommendation. ICD will be implanted for patients who developed arrhythmia or aborted sudden cardiac death, and following implantation of ICD, resumption or leisure or competitive sports should be considered after shared decision making in individuals who have not experienced current arrhythmias over 3 months after ICD implantation. That's to say that patients with long QT syndrome with implanted ICD who for sudden cardiac death will not undergo, are prohibited to undergo exercise participation, sport participation. However, patients with Brugada syndrome can be allowed to resume very competitive sports after ICD implantation. However, you have to take care that to avoid sports that increase the core temperature of them. Endurance under extremely hot or humid condition should be avoided. Also avoid drugs that can aggravate the presence of Brugada symptoms. Lastly, we'll have the recommendation following device implantation. The key message: you have a pacemaker or an ICD. Pacemaker is easy. You can exercise with a pacemaker. However, with ICD, there are some risks related to the psychological impact on the patient and other issues we'll discuss right now. So patients with implanted devices or CRT should follow the recommendations related to the underlying conditions, should avoid collision sports in order not cause any harm for the pacemaker. We can exercise and we have padding for at the place of the pacemaker and the lead. Holter recording and device interrogation should be done after resuming the sports, and ICD is not recommended as a substitute for disease-related recommendation when these mandate sport restriction. As we have mentioned, the ICD is not the solution for the long QT syndrome in order to resume sports, and the same may apply as Dr. Zahan asked about the hypertrophic cardiomyopathy. Last topic, because we are so late, the congenital heart disease. Congenital heart disease, we have to assess 5 parameters before advising the patient to undergo sport with congenital heart disease. We have a ventricular function to be assessed by echo. In complex conditions, the CMR may be preferable. Pulmonary pressure, we have to assess the aortic size by echo or CMR for coarctation to be excluded. Assessment of arrhythmias by 12-lead ECG, and assessment of the saturation by pulse oximeter. Why is this important? Because participation in regular moderate exercise is recommended in all individuals with congenital heart disease, and we have to assess all the above mentioned parameters for a patient undergoing exercise with congenital heart disease. If they have if we are in NIHA class 1 or 2 who are free from potentially serious arrhythmias, after tailored evaluation, we can undergo exercise. However, competitive sport is not recommended for patients with NIHA 3 or 4. And this is the general recommendation for pre-participation assessment of individuals with congenital heart disease. As we have mentioned, the green can undergo high intensity sports who have normal LV function, no hypertrophy, no volume or pressure overload, low pulmonary artery pressure, normal or mild dilatation of the aorta, no arrhythmias with no central cyanosis. They can undergo high intensity sports. However, on the other side, severe systolic dysfunction or elevated pulmonary artery pressure or significant arrhythmias or malignant arrhythmias, if at least one is applicable, we recommend only low intensity sports. So lastly, the key messages to sum up what we have mentioned in our lengthy topic today, that cardiovascular screening before participation is aimed at detection of disorders with sudden cardiac death and has the potential to lower cardiovascular risk through disease-specific and individualized patient management. Cardiovascular screening in adult and senior athletes should target the higher prevalence of atherosclerotic coronary heart disease because they are at risk beyond the age of 35 years. Healthy individuals should exercise on most days, totaling at least 150 minutes per week of moderate intensity exercise. Patients with coronary heart disease at low risk of exercise-induced arrhythmias should be considered eligible for competitive or leisure sports with few exceptions. Competitive sports are not recommended in patients with coronary heart disease at high risk of exercise-induced adverse events or with residual ischemia, with the exception of individually low-intensity skill sports. Exercise programs in heart failure improve exercise tolerance and quality of life with positive impact on mortality and all-cause hospitalization. Asymptomatic individuals with mild valvular heart disease may participate in all sporting activities, including competitive sports, and a selected group of asymptomatic individuals with moderate valvular disease, as we have mentioned, who have good functional capacity and no myocardial ischemia or arrhythmias or hemodynamic impact, may be considered for competitive sports after careful discussion with an expert cardiologist. Implementation of healthy lifestyle behaviors, including sports participation, decreasing the cardiovascular events and mortality in individuals with aortopathies. Our patients with acute myocarditis and pericarditis should abstain from all sports while active inflammation is present. Individuals with cardiomyopathy or resolved myocarditis or pericarditis who wish to participate in regular sports should undergo comprehensive evaluation, including an exercise test to assess the risk of exercise-induced arrhythmias. Also, patients uh, patients who are genotype positive, phenotype negative, or have a mild cardiomyopathy phenotype and absence of symptoms or any risk factors may be able to participate in competitive sports. A notable exception is arrhythmogenic cardiomyopathy, where high intensity exercise and competitive sports should be discouraged, as we have mentioned. What about patients with arrhythmogenic conditions? Well, they are guided by three principles: prevention of life-threatening arrhythmias during exercise, symptom management to allow sports, also prevention of sports-induced progression of arrhythmogenic condition. In each case, these three basic questions need to be addressed. In patients with paroxysmal supraventricular tachycardia, pre-excitation should be excluded, and ablation of the accessory pathway is recommended if present. Patients with PVCs who want to engage in sports underlying structural or familial arrhythmogenic condition must be excluded, since sport activity may trigger more malignant arrhythmias if those underlying conditions are present. Also, athletes with electrical abnormalities of genetic origin, like channelopathies, require assessment and shared decision making, in which the cardiogeneticists are involved, given the complex interplay of genotype, phenotype, potential modifiers, and exercise. Individuals with pacemakers should not be discouraged from participation in sports because of the device, but need to tailor their sport participation according to the underlying disease. Patients with ICD contemplating participation in leisure sports or competitive sports may be considered, but require shared decision making because of higher likelihood of appropriate and inappropriate shocks during sports and the potential consequences of short episodes of loss of consciousness. Lastly, patients with congenital heart disease should be encouraged to exercise and should be given to personalized exercise prescription with the physician specialized in congenital heart disease. And with this is all we have discussed today. Last time about healthy individuals. We have discussed today about patients with coronary heart disease, patients with heart failure, recommendation, valvular heart disease, and aortopathies. These are the summing of recommendation with patients with cardiomyopathy, whether hypertrophic, arrhythmogenic, LV non-compaction, dilated cardiomyopathy, myocarditis, and pericarditis, and the recommendation for patients with arrhythmias and implantable cardiac devices, and lastly, congenital heart disease. I'm sorry for the lengthy topic and many new information and complex discussion, but thank you for all.
Thank you so much, Yasser. It was an elegant
Thank you.
it was an elegant presentation through a heavy topic, but you make it easy. I'd like to ask you a practical question regarding the component of cardiac rehabilitation centers.
Yes.
Which specialties and equipments would you need, and what is the protocol you would apply in the cardiac rehabilitation center?
The protocol we apply, we need, of course, a setup room that accommodates a treadmill and a monitor to monitor the patient while exercising. Also, we can train the patients on the treadmill exercise. Of course, we can do some resistant exercise, which is not available so much in Egypt. We are preparing this one in our specialized hospital at Ain Shams University will be a comprehensive center for this. This is for the setup of cardiac rehabilitation unit. If we have a patient after sustaining an acute coronary syndrome, mostly, or heart failure patient, these are the most common patients who present to our center. For the patient after sustaining an acute coronary syndrome, we discuss with him the absence of any contraindication for exercise. We ensure that the patient for the acute coronary syndrome is fully revascularized before attempting to exercise the patient. We assess his LV function. We optimize his medical treatment. And then we do a preliminary exercise test. We exercise the patient on a modified Bruce protocol, and we tailor the exercise prescription thereafter according to the achieved METs and the heart rate achieved and the number of minutes achieved on this exercise baseline exercise test. And we tailor after that according to an estimated equation analogous to low intensity or moderate intensity up to high intensity, starting at 40% of VO2 max, or according to the Cauldron formula I mentioned in last lecture, for about 4 weeks. Then switching thereafter to a higher moderate intensity, about 60%. And if the patient can tolerate, we can move to the moderate to high intensity to about 80% of heart rate reserved achieved during the exercise, gradually increasing. The exercise session starts by 5 to 10 minutes warm up, then followed by around 20 to 30 minutes on the treadmill, then followed by a 5 to 10 minutes cool down period. During this period, the patient is monitored by a nurse for developing of symptoms of chest pain or arrhythmias or hypotension during the exercise. This is for the patients with acute coronary syndrome. But for patients with heart failure, we risk stratify the patient. If the patient has low ejection fraction, we have to optimize his heart failure medication first of all on maximal tolerated medical treatment, including the CRT implantation or whatever. Then the patient can, and we do the exercise test at first, and then we tailor the exercise prescription according to the achieved activity for the patient. Usually, we do low to moderate intensity exercise test for the patients and follow them up for about 3 months. We also recommend do recommendation for the patient while coming to the rehabilitation unit 2 to 3 times per week, in order to, in parallel, to do, he can exercise or do moderate exercise like walking for about 30 minutes per day in parallel with attendance at our unit. And after the 3 months sessions, 3 months cardiac rehabilitation attendance, we can ask the patient after that, in order to do regular physical activity as recommended by the guidelines. He can walk for about around 150 minutes a week, can increase to about 300 minutes as recommended for the patients, and follow up his risk factors. Also, I forgot to mention that during his attendance for cardiac rehabilitation unit, so we do some recommendation as regards control of his risk factors, as regards hypertension, diabetes control. He can have session with the nutritionist to give him advice as regards what to eat, how to arrange his meals, like this. Sometimes some patients we recommend attending smoking cessation advice sessions. One of our colleagues in the chest unit can help patient to abstain from smoking. If he's addict for smoking, he cannot stop smoking. This is for the cardiac rehabilitation unit.
Thank you, Yasser. This is a great practice and protocol that needs to be generalized in every cardiac center in Egypt. Thank you indeed.
Thank you so much, Yasser, for the wonderful presentation first and for elaborating the components of the cardiovascular rehabilitation program ongoing at Ain Shams University. It was a really heavy session, full of clinical data and full of guidelines, which is actually important for us to know. And at the end, you wrapped it up in the points that need to be known in every particular situation, whether it is heart failure or coronary ischemia or valvular or congenital or even arrhythmias and channelopathies. So our dear viewers, we will be streaming again regularly every Thursday at 9 p.m. and we will always be glad to have you all on board. I would like to thank Dr. Yasser Ala for joining us tonight, Dr. Haitham and Dr. Kareem for moderating with us this session, and hopefully we will see you next week.